Hi, everyone. Welcome to Aging with Insights. My name is Kyle Purcell. I work here at St. Joseph's Health Center Foundation. Thank you very much for joining us today. Um, we're letting everyone in. We've got a great turnout this morning, so we will give about a minute for everyone to arrive, and then we'll get started. During that time, I have a couple of housekeeping notes to go through. So to start off with, I'll just let everyone know that the presentation is being recorded, and we will share a video of the presentation along with the slides on our website following the session. And you can find that at supportstjoes.ca/agingwithinsight. Um, in order to ensure a smooth presentation, we ask everyone to keep themselves on mute as well as to keep their cameras off. We will have a opportunity for a Q&A following Dr. Anselm's presentation. You can find a Q&A function at the bottom of your screen, and if you enter your questions through there, we'll be reviewing those throughout, and I will then ask Dr. Anselm your questions at the end of the presentation. All right, and I think we can jump right in. And so I will hand it over to my colleague, Julie Castle, for some introductory remarks.
Perfect. Thanks so much, Kyle. Welcome, everyone. It's so wonderful to have so many of you joining us today for our Aging with Insight session. Today's topic, as you can see, is cardiac health. And we are so fortunate to have St. Joe's expert, Dr. Anjali Anselm, joining us to share her insights. But first, we'd like to extend our sincere thanks to the Slate Family Foundation, whose generous support to seniors' health has made this series possible. My name is Julie Castle, and I'm the Vice President of Development at St. Joseph's Health Center Foundation. I'd like to take a moment to acknowledge the land on which St. Joe's operates. This is the traditional territory of many First Peoples, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land remains home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Before we get into today's presentation, and while waiting for everybody to join in, I'd like to share a few St. Joe's updates with you. Our West End community is rapidly expanding, increasing the demand for specialized medical services. And currently, St. Joe serves a community of more than 500,000 people and growing. The support and generosity of our donors and our amazing community have enabled us to create many new spaces that enhance care for you and your loved ones, such as the St. Joe's Bigger and Better Emergency Department. Over the past few years, our emergency department underwent an extensive renovation and expansion in what's been the single largest fundraising project in the hospital's history to date. I'm excited to share that the transformation is complete and features 40% more space, advanced technology, and specialized zones of care. What's even more incredible is that this project is 100% donor funded. We have so much more to do and exciting plans for the future, including expanding key areas such as our ambulatory care department, surgical spaces, and mental health care programs. If you'd like to make a gift or to learn more about this exciting work, I invite you to connect with me. My contact information will be on the screen at the end, and you can always follow our impact our community is having at supportstjoes.ca. Now, I'd like to introduce you to Dr. Anjali Anselm. Dr. Anselm, as I mentioned, has been a well-respected cardiologist at St. Joe's for over 15 years and is currently the division head of cardiology. Dr. Anselm is also president at Riverside Cardiology and Diagnostic Imaging. In addition to her amazing work at St. Joe's, she is also the captain of a cycle for St. Joe's team, the Cardiac Pacers, raising critical funds for the cardiology department. Welcome, Dr. Anselm, and thank you for taking time to speak with us today.
Thank you, Julie and Kyle, for that introduction, and welcome everyone. Thank you for joining the talk. I'm just going to share my slides. Is it projecting okay?
Yes, it is.
Okay, perfect.
Thank you.
All right, so today I'm going to talk to you about cardiovascular health and as we age, and sort of what are the best things we can do to maintain a healthy cardiovascular system as we go through the process of aging. I don't know how many of you may recall this commercial from the 1980s. It's an Oil of LA commercial. And the tagline used to be, "I don't intend to grow old gracefully. I intend to fight it every step of the way." And, in the 80s and early 90s, this really was the philosophy, is that we were not going to age like our mothers or our grandmothers did. We weren't going to just sort of, sit on the couch and allow old age to take over. We were going to fight it. We were going to stay young and youthful and try to maintain our bodies, our faces, etc., like we did in our 20s and 30s. But I think, reality did set in, and there was a recognition that you cannot fight age. Age is a process that affects all of us. We are all subject to it. And the best thing to do is to accept it and then do what you can to best age well. Then came the growing old gracefully approach, sort of, I'm not going to fight it, I'm going to old age gracefully. And this picture sort of alludes to that, where you have this beautiful sunshine in the background, you're walking leisurely in your retirement, things are slowing down a little bit, but you're sort of just going to be at ease with the aging process. However, I think that things have changed somewhat, and now we have a newer approach to aging, which is embracing aging actively. That you want to participate in aging, you want to engage in the aging process and do everything you can to be as active, as energized, and as engaged as possible. This really is where things are at now. How do we come at this, aging well, aging actively from the cardiovascular standpoint? So the first thing I would like to say is, as a cardiologist, it really is a privilege to grow old. I see lots of patients, some very young, who have significant cardiac conditions like cardiac arrhythmias or genetic abnormalities, inherited arrhythmias, or inherited cardiomyopathies, inherited cardiac conditions where they have significant illness when they're quite young. People can often die at an early age. So having the opportunity to grow old well is a privilege, and we need to recognize that and sort of embrace that, and in appreciation of that, take care of ourselves as we grow old. One thing that I always say is that you want to grow up well. What do I mean by that? I start telling my young kids, I want you to grow well. What does that mean? That means mentally, emotionally, physically, nutritionally, actively growing well. This really starts from day one. From the time you are actually even an embryo, to the time you're an infant, to a child, to an adult, and into your later years, it's the same process. We're all growing up well from the start. But the same goals are maintained throughout our lives. We use the same tools, which I will discuss in a bit more detail. We just use the tools in a different way in order to help us grow up well from one day to the next, whether it's in our teens, 20s, 60s, 70s, etc. One of the main things from a cardiovascular standpoint is that you want to maintain optimal cardiovascular structure and function. So you're trying to maintain the health of the actual structures of your heart and your cardiovascular system. So this is all of the blood vessels. Our goal is to minimize the risk of cardiovascular disease and to preserve lifespan, meaning, live as long as we potentially could. One of the most important things, I think, for all of us is that you don't just want to extend the quantity of your life, You want to extend the quality of your life. You know, all of us are not looking to live to 90 with a lot of illness. We want to live to whatever age we're supposed to live with an excellent quality of life. And so maintaining cardiovascular health is very, very important in having good quality. So I'm first going to just briefly touch upon the changes that happen as we age, and then it's sort of the rest of the talk, you know, is about how to minimize those changes or to make those changes as least impacting on our lives in a negative way. As we get older, there are progressive changes that occur to our heart and our blood vessels or the vasculature. You start to get stiffening of the arteries of the heart. Everything really stiffens with age. You know, our joints stiffen, so do our arteries. You start to get changes within the endothelial lining. So endothelial is the arterial lining. It's those cells that line the inside of the blood vessels. You start to get dysfunction with those cells. And we know that that impacts the cardiovascular system in a significant way. You start to get increased inflammation as we age. And this also causes a lot of deleterious effect on the entire cardiovascular system. And you get molecular alterations, the actual genes, the proteins they produce, the molecules and cells that thereafter come from that actually alter with age. So pictorially here, these are the blood vessels in our cardiovascular system. Can you see my pointer?
Yes, we can.
Okay, perfect.
Yeah.
All right, so
Thank you.
this is the arterial wall, and this is the endothelial lining. So it's the actual lining of the blood vessels, and these are very critical structures, and they change with age. They become stiffer. They are prone to inflammation. You can get cholesterol buildup, plaque over here. And this is how you start to get blockages and tiny little blood clots forming within the arteries of the heart. So the actual the actual vascular system or blood vessels change with age. Also, the muscle of the heart can change with age. You know, as it is exposed to high blood pressure or to heart attacks or certain toxins or nutritional deficiencies, etc., the actual muscle of the heart can start to change. The arteries of the heart, these are the ones that lie on top of the heart muscle, as I said, can get blockages and stiffening. The large blood vessels coming in and out of the heart can change. The pressures within the heart and the pressures as one chamber communicates to another can also change with age. And then you can get inside the heart changes with respect to the valve function. If they can either become very stiff or they can become floppy and leaky with time. So multiple different things within the cardiovascular system can change with age. And so all the suggestions I'm going to give you are aimed towards minimizing these changes or helping your body cope with the changes that are going to happen because of genetics, etc. So first, I'm going to talk about the things that we should not do, because these are easy, straightforward, and to the point, okay? So don't smoke. If you are a smoker, do your best to quit or at least minimize the number of cigarettes you are smoking. If you have quit smoking, don't ever pick it up again. Smoking is just terrible for the cardiovascular system. Don't use recreational drugs. You know, since marijuana has been legalized, a lot more people are using it, especially young people, but also a lot of older people who use it when they were much younger. And we do know that there can be arrhythmias and other things brought on by things like marijuana or cannabis, and then even obviously other drugs like, you know, cocaine, heroin, all of that, just avoided completely. Do not leave medical conditions untreated. So if you have cardiac conditions or non-cardiac conditions, make sure that they are appropriately treated. Any medical condition that's untreated will put undue stress on the cardiovascular system. Don't stop taking your medications without informing or discussing with your physician who prescribed them. You know, people do have side effects. Many people don't like to take a lot of medications, but it's really unadvisable to stop taking medications or change the dosing without discussing it with your physician. This can have a really, awful impacts on your cardiovascular system, especially as you age. And the other thing I would say is do not pay for unproven treatments like supplements, etc., which cost a lot of money and may add absolutely no benefit, but could in fact increase your risk from a cardiovascular standpoint. And I'll get into this a little bit later on as well. So these are the things that you should not do. Well, what can you do for cardiovascular health as you age? In fact, a fair bit. There's lots of data showing that there are lots of changes that you can make to improve your cardiovascular health as you age. So what are the main factors that we need to think about when it comes to preserving cardiovascular wellness as we get older? So you want to have ideal levels of blood pressure, cholesterol, body mass index or weight, sugar control, physical activity, healthy dietary patterns, adequate sleep, and early detection of these or any other medical problem, and then intervention early on. I'll go into each of these in detail, but really it's very important to identify these if they are an issue for you and to get on top of things as early as possible. The longer things are left untreated, the more damage is caused to the cardiovascular system. And then in fact, sometimes that damage can be irreversible, even if you do start to make change. So blood pressure. Everyone thinks about 120/80 as the perfect blood pressure, and that is in fact the perfect blood pressure. But when it comes to actually diagnosing or treating blood pressure, we really don't do anything until it's around 130/80. And then at that point, our goal is to get the blood pressure down to below 130/80. Okay. Sometimes for older people, we can accept higher blood pressure numbers. In particular, if someone has many other medical issues that predispose them to having side effects, if they are on many medications where you can get a lot of drug interactions. So there we will sometimes accept a higher blood pressure. If someone's very frail and predisposed to falls, again, we will accept a little bit of a higher blood pressure as people are older. I'm talking late 70s, 80s, especially into the 90s. Then we are less aggressive with bringing down the blood pressure if someone's frail. And obviously, if someone's having a lot of side effects to any blood pressure medication, then we sort of back off to avoid side effects. So as people get older, now again, I'm talking, late 70s, early 80s, 90s, etc., we can accept blood pressure targets of less than 140/90. And sometimes we will even allow less than 150/95, especially if there are a lot of negative side effects to medication. If you have high blood pressure, the most important thing really is to start off with lifestyle changes. That's the first thing that we do. So what can you do in terms of lifestyle changes? So limit your sodium or salt intake. We say the maximum intake you should have if you have high blood pressure is 1.5 to 2.5 grams of sodium per day in your diet. So what is that from a practical standpoint? That's at about 1/2 to 1 teaspoon of your total salt intake. So this is not just what you add, sprinkle onto your eggs or add into the water that you're cooking your pasta. And this is the salt in bread, the salt in soups, the salt in anything that comes canned or processed. So it's very important if you have high blood pressure, to look at the salt content in everything that you're eating and ensure that that's minimized to 1/2 to 1 teaspoon of salt. And this adds up very, very, very quickly. So it really is cutting out a fair bit of salt from your diet in order to bring down the blood pressure through salt restriction. The other thing that can help is using the DASH or Mediterranean diet. The DASH diet is in particular targeted towards lowering blood pressure. The Mediterranean diet is more for general cardiovascular wellness. I'll get into more details about these diets a bit later on, but diets certainly can help with reducing blood pressure. Weight loss helps with reducing blood pressure. Even if you lose, 5 to 10% of your baseline body weight, that can reduce your blood pressure several points and help avoid medication or reduce the number of medications that you need. And we often suggest, that weight loss should be gradual. Fad diets that have you lose a ton of weight very rapidly, you can drop your blood pressure quite significantly, but then often when you gain weight, the blood pressure just skyrockets way back up. So we always encourage weight loss done carefully and judiciously, using the right approaches that allow you to maintain weight loss over a lifetime rather than, 6 months or 1 year, etc. A regular aerobic and resistance exercise also help with reducing blood pressure, and I'll get into further details about that in a bit. And the other thing is reducing your alcohol consumption. So when we're talking about blood pressure, we want to keep our alcohol consumption to less than 2 drinks a day for men and less than 1 drink per day for women. Above this, your blood pressure does go up with increasing alcohol consumption. I want to be clear, this is related as it relates to blood pressure. For general health now, the guidelines are that, minimizing alcohol to, 1 or 2 drinks a week for men or 1 drink a week for women is probably, okay. And there's some guidelines, and this is general health guidelines, that are saying no alcohol is best. And that has to do with things like memory, dementia, liver disease, etc. But from a blood pressure standpoint, you don't want to go above 2 drinks for men per day or 1 drink for women, because that will drive up your blood pressure. So what are the sizes of the drinks? So a beer would be 12 ounces, just standard size, not the tall boys. For wine, it's 5 ounces of wine is considered 1 serving. In most restaurants, they offer you 6 or 9 ounces, which is much larger than what the standard size for wine is considered, and 1.5 ounces of distilled spirits like scotch or vodka or whatever. The other thing that you want to do from a lifestyle standpoint, in terms of managing high blood pressure without the use of medication, is screen for sleep apnea. It's a notorious cause for high blood pressure. So in people who snore, people who are overweight, people who feel like they never get a good night's rest, they might have sleep apnea, and this could be contributing to high blood pressure. So screening for this is important, as it is a non-pharmacologic way of managing blood pressure if it is present. Now, I have here a picture of the blood pressure cuff with a ton of medication, and often what does happen is that people do need a lot of medication for controlling blood pressure, unfortunately. So while lifestyle measures can work, they actually can be limited in lowering blood pressure in those who are over 80 years of age. And even below 80 years of age, lifestyle changes often don't work. A big part of that is that if you are used to a certain lifestyle for decades, it can be very hard to transition to a new lifestyle. Also, just genetically, you might be predispositioned to having high blood pressure, and no amount of lifestyle change is going to impact that significantly. So medications often are needed. The average person needs 2 medications for treating high blood pressure alone. Many patients need 3 or 4 medications, especially if they have other medical problems. There are many options out there, lots of good choices for blood pressure medication. So if you're having a side effect to 1 or more medication, there are alternatives. Many medications now in combinations where you have 2 pills, 2 medications in 1 pill. So you actually consume fewer pills, and this can be easier for some patients. So again, controlling blood pressure is extremely important for maintaining good cardiovascular health. Cholesterol. So controlling cholesterol is also very important, but interestingly, there's no universally established cholesterol targets, meaning no specific, bad cholesterol level to get down to for elderly patients. So in elderly patients, it really is an individualized approach where we look at other comorbidities, so other conditions that patients may have, whether it's a stroke, a heart attack, diabetes, etc. We look at patients' functional status, that's how mobile and active they are. We look at their life expectancy. If someone's going to live, has a good chance of living another, 15 or 20 years, we're a bit more aggressive. If someone's going to live probably 2 or 3 years because of cancer or something like that, then we're less aggressive. And then often in the elderly, we take in patient preference. Treating cholesterol is sort of a lifetime thing and reducing your risk over, many years to decades. So if you don't have that lifespan left and you just don't want to take that many pills, sometimes we will back off. But again, this is in the elderly and not in, younger old patients. So not in your 60s or 70s, closer to your 80s or 90s, we are less, generally less aggressive. We do know that in patients who have had a heart attack, angina, stroke, or established plaque or blockages anywhere, that there is a significant benefit to treating the cholesterol, and we're fairly aggressive with very tight limits for lowering the cholesterol, because we know that if you do have blockages or plaque, we want to get that cholesterol down as aggressively as possible. The reason is that atherosclerosis is a condition that really can be present from the head to the toes, because your arterial system goes from your head to your toes. So if you do have plaque or blockages within the carotid arteries, which are the ones in the neck that are supplying the brain, then you can get a stroke or a mini stroke, or TIA is a mini stroke. If you have blockages in the arteries that are within the heart, you can have acute coronary syndrome. So this would be your heart attacks, angina, etc. If you have blockages in the lower extremities or within the aorta, which is a large blood vessel coming down into the legs, You can get claudication, which is a particular kind of pain in the calves. You can get aortic aneurysms and aortic ruptures, etc. So we are very, very, very aggressive if you have established atherosclerosis. Less aggressive with no definite targets if you don't have atherosclerosis, but you do have high cholesterol. We also know that there is benefit to starting treatment of cholesterol if the cholesterol is elevated, even without established blockages. So we know that there is benefit to this. We do reduce the chance of having a cardiovascular event like a stroke or a heart attack. We just don't have a very, very specific target for how low we should go. But we do know that some medication is better than no medication. But as I mentioned, there are circumstances in which we are less aggressive, and sometimes we will stop medication, as that may be the better option in an elderly patient. As I said, very frail, lots of other illnesses, or very limited life expectancy, then you just don't need to be as aggressive. You can even stop using the cholesterol medication. You know, as a cardiologist or a family physician or an endocrinologist, you know, when we look at patients, this is how we think about things, right? So we know that people can have side effects and adverse events related to statins. They can have muscle aches and pains. They just don't feel well on it. But we are also looking at the other side of the balance, right? What are the benefits? And the benefits are indisputable, well established with data looking at millions of patients over multiple decades. We know that statins and cholesterol reducing medication reduces death. It reduces hospitalization. So people who take their statins end up in hospital less frequently. We know this. It's clearly established. And it also protects people from really serious illness, you know, like a stroke or a heart attack. Both can leave you with significant disability. So in terms of the total benefit and quality of life, it is significant, and it far outweighs the side effects. So we always tell patients, you know, you read a lot of stuff online about the downside of statins, and there are some downsides, but the benefit, the upside is much, much, much greater. So at the very least, try it. If one is not working for you, try another one. There are multiple options out there of how you can reduce your cholesterol with a medication if needed. Now we're going to move on to weight and management of weight. So the medical calculation that we use is something called the body mass index. So this is a measure of weight relative to your height. Obviously, taller people will weigh more. So we use the body mass index as sort of a guide on, you know, what is a healthy weight. So a healthy BMI for aging patients is generally considered between 23 and 28. For younger patients, it's often between sort of 21 to 25, but as people get older, the weight limit actually goes up. We know that in aging patients, being underweight, so having a BMI of less than 23, or being obese, which would be a BMI of greater than 33, is associated with increased death and disability. So we always hear, you know, about the downside of being overweight. But as you age, particularly into your late 70s, 80s, 90s, being underweight is a problem because you just don't have that reserve if you lose too much weight. And by reserve, I mean like if you get a pneumonia or some other, you know, infection or whatever, you need to have weight on you in order for your immune system to work in order to be able to fight off ill health. So being underweight is a problem as you get older. So the BMI is affected by your bone mass. So the thicker your bones, the higher your BMI will be. Your muscle mass, so people who have more muscle than fat will have a higher BMI. And it's different for different individuals. So that's why we say, you know, there's a range in terms of what is a healthy BMI. It is not a perfect measure at all, but it is an easy calculation, and it's very cost effective in terms of, you know, a quick way of establishing if someone's weight is in a reasonable range. And there's lots of scales online that help us, you know, to calculate this, and I'll show you one scale in a second. One thing I will say about fat and the fat distribution is that fat that is called visceral fat, or fat that's within the belly over here and surrounding the organs, is actually more unhealthy than fat that is just under the skin, or fat that might accumulate, you know, like on your thighs or your buttocks or your arms or whatever. That is subcutaneous fat, you know, that's in other parts of the body, and that's not as bad, I mean, bad for you, but it's not as bad as the visceral fat. The visceral fat is the fat that's actually surrounding the organs. This fat produces all sorts of toxic hormones and other chemicals that can cause inflammation and other deleterious effects on the cardiovascular system. So BMI is important, you know, in terms of total weight to height, but it's also fat distribution. This is the body mass index calculator that you can find online at Diabetes Canada. It's very simple. You put in your weight and it allows you to select either in pounds or kilograms. You put in your height in centimeters or inches, and it calculates your BMI for you. So, you know, one of the important things, you know, if you're just going to calculate your BMI sort of trended, you know, year to year, is your BMI going up in the wrong direction? And to keep an eye on that. You know, if your BMI is out of that healthy range that I specified, you know, maybe you need to eat healthier food to help you gain healthy weight or make changes to help you lose the weight. So it's just a good guide and not something that you should follow, you know, very strictly, you know, by the law. The next thing I'm going to talk about is sugar control. So sugar control is very important, extremely important. It's one of the most toxic substances out there, actually. So if you have diabetes, it definitely needs to be treated. If you are diabetic, it's very important to take your medication regularly as prescribed by our doctor. As with cholesterol, as with blood pressure, we are slightly less aggressive as people get older, again, into your late 70s, early 80s, 90s, etc. We'll accept it. For those of you who are diabetic, you'll know what this is. An HbA1c, which is a measure of your sugar over 3 months or so. We'll accept 7.5 to 8%. For people who are younger, we want stricter sugar control, you know, 6 to 7% of target for HbA1c. In the elderly patients, we have a looser limit because it's very important to avoid low blood sugar. Low blood sugar can have lots of negative impacts, particularly on the brain. If you are not diabetic, it is still important to control your sugar intake. High sugar is associated with increased cardiovascular disease, fatty liver disease, certain types of cancer, chronic inflammation, and increased death. The highest risk is with added sugars, so not sort of the natural sugars you find in fruits and vegetables and all that, but sugar that's added as part of the processing. And sugar sweetened beverages are terrible. So this is your pops and colas and that sort of thing. In terms of artificial sweeteners, the benefits versus the risks of artificial sweeteners is actually not clear. There's some data showing that artificial sweeteners can increase your cardiovascular risk and cancer risk. So, you know, often they're not a better alternative to regular sugar. I'm going to touch upon briefly the Ozempic category of drugs because they are new and there is so much interest in this out there. So these are the GLP-1 or GIP category of drugs, and they include things like Ozempic, Wegovy, Mounjaro, etc. So these drugs were initially created for diabetes, but now we see it actually helps also with weight loss and reducing your cardiovascular risk. It actually reduces the incidence of cardiovascular events. We don't fully understand why, and there's lots of research going on in this field, but we are seeing the data showing this. This category of medications is recommended for people with diabetes, also for patients who have atherosclerosis. So if you have blockages or if you are at high risk for blockages, then these medications are being used more and more. In fact, we have data now showing that it reduces the incidence of heart failure, whether you're diabetic or not. So there's a lot of benefit that we're seeing from these medications. As well, we're seeing some signaling that it helps to improve cognitive function. So this is with respect to the risk of dementia and gait disturbances, meaning, you know, your steadiness as you walk, as you get older. So we are seeing that this category of medications has significant benefits. There are definite side effects, and your doctor will discuss this with you when prescribing these medications, but they're certainly not a medication to be afraid of. And they are a medication to be considered given the significant potential for reducing cardiovascular disease that we are seeing now in the data. Now I'm going to move on to physical activity. So we do recommend regular aerobic and resistance exercise as you get older for reducing your cardiovascular risk. With respect to aerobic exercise, we recommend a minimum of 150 minutes per week. So that's at least 30 minutes for most days of the week. Now, people often will ask me, how high should I get my heart rate? And so the medical cardiac technical target is 65 to 75% of your heart rate reserve. And I don't expect any of you to use this or remember this, but essentially the heart rate reserve is your maximum predicted heart rate. This is based on your age minus your resting heart rate. Now, again, don't do this calculation, but all of this to say that we do have specific targets that we want people to go to, but this is often adjusted based on medications that you're using, your other medical conditions, etc. So this is not to be used by the lay person. What I tell people is just do something that's moderate intensity. So brisk walking, swimming, cycling, rowing, these are active, moderate intensity activities. And I often say that the best way to gauge it is that whatever you are doing for 30, 40 minutes at a time, you should be sort of panting and breathing deeply. If you're just feeling like you would be as if you're sitting on the porch talking, that's not enough exercise. But if you're laboring so much that you cannot finish a complete sentence in speech, then that's a little too hard on your body. So basically, you should be panting and breathing deeply as you're doing the exercise for about 30, 40 minutes a day. So as I said, brisk walking, swimming, cycling are excellent exercises to do as you get older for your cardiovascular health and also for your muscles, your joints, your bones, etc. And for your mind, your mental health. Very, very important. Some more information on resistance exercises. So this is also very important for maintaining your muscle mass and tone as you get older, for preventing against osteoporosis and in general for cardiovascular health. So we recommend at least 6 different types of resistance exercises, 3 sets per exercise. So for example, if you're doing curls with light weights, you want to do 3 sets and 10 repetitions per set. We suggest light weights, such as these. It does not have to be heavy weights. You can do some hand grip exercises, whether it's, squeezing one of these types of hand grips or, one of these stress ball things that you can squeeze. And then also resistance bands can be very helpful to either pull them with your arms or, hold them and push your legs against the resistance bands to increase the muscle tone in your legs. So it doesn't have to be anything expensive. You can use a lot of things that are very easily obtained. Consider low-cost or free exercise classes at senior or community centers. These are a great opportunity for not only exercise, but for social engagement. And I really encourage you to think outside the quote-unquote box or the gym. To stay healthy with respect to aerobic and resistance exercise, you do not need to go to a gym. You can do dancing classes, go join a dog walking group. If you can't do an activity because of, arthritis or spinal stenosis or some kind of sciatica or any kind of neuromuscular problem, instead of doing, 1 30 or 40-minute session, break it up into 4 or 5-minute sessions throughout the day. And I'll tell my patients, in your house, walk up and down the hallway for 5 minutes, 4 or 5 times a day. If you live in a condo building or any other building, get out into the hallway and just walk for 5 minutes at a time. You don't even need to put a coat on in winter. It does actually help to aim for 7,000 to 10,000 steps, 7,000 to 8,000 steps as you get older. Obviously, if you're younger, 10,000 steps is a good step goal. But as you get older, 7,000 or 8,000 steps is perfectly good. And for some people, as they get older, this is their version of getting older. They have a fancy gym membership. They do a lot of weights. They participate in spin classes. And they're okay, spending the time and money on this. And that works very well for some people. But this is not what I'm suggesting or saying that you should target. This works very well, in a group, doing dance classes, line dancing, whatever, going with the group for dog walking. You can socialize, you can get out into the fresh air, your dog gets a walk, etc. So think of different ways to get out and be active and engaged. With respect to diet, there are the DASH diet I had mentioned earlier. This is specifically for high blood pressure, but it also has cardiovascular benefits. And it's recommended as the first strategy for elderly patients with high blood pressure. And this is sort of what the diet looks like. Lots of grains, fruits and vegetables, daily sources of healthy oils like olive oil, coconut, even eggs and avocado, nuts and seeds several times per week. limit the amount of animal-based protein that you're getting, and fat-free or low-fat dairy in the diet. This is what the diet looks like if you look at it pictorially. So this is what your grocery cart, what your fridge should look like, what your kitchen counter should look like when you're preparing meals. Lots of fruits and vegetables, some protein, and lots of whole grains. The Mediterranean diet is the other diet that's recommended. So the DASH diet that I just mentioned is for high blood pressure. The Mediterranean diet is for just general cardiovascular health, but this data that it reduces high blood pressure, reduces frailty, improves physical function, reduces falls, it improves cardiovascular function, depression, and overall quality of life. So this diet, again, lots of fruits, vegetables, whole grains, extra virgin olive oil, nuts, legumes, fish, lean meat, poultry, low-fat dairy. They limit the serving to actually just one per day. And then it does allow for some red meat and sweets, but limited to about once per week. So it's not a restrictive diet. It allows you to have many different things. It's just that the proportions are such that it favors the fruits, vegetables, etc., and reduces the amount of red meat and sweets. And this is what the Mediterranean diet should look like. So again, lots of options, lots of color, lots of flavor, lots of texture to it. It's not restrictive. You are allowed to have, meat up here, but again, it's the portions that are reduced. You have small amounts of red meat, lots of other stuff over here. It allows for carbs. So, I'm very much against these very restrictive, high protein, keto type diets. You can lose weight very rapidly, but the cardiovascular effects of that are really deleterious and not advisable. The other important thing that we want to get is adequate sleep. So you want to get 7 to 8 hours of sleep recommended for the elderly. Less than 5 hours or more than 8 hours is actually associated with increased cardiovascular disease. Obviously, there's some variability in that. Someone who's been sleeping 9 hours their whole life, I would not suggest suddenly reducing it to 7 or 8 hours. But in general, if you're not getting enough sleep or you're spending too much time in bed, it's not good from a cardiovascular standpoint. As we get older, sleep does become more fragmented. You get fewer hours of sleep. It takes much longer to fall asleep. We may wake up more often, either just because our body wakes up or you have to go to the bathroom, and often can be very difficult to maintain long periods of sleep. We also get more sleep disorders as we age. You get more sleep apnea and more restless legs or periodic limb movement, which can be quite disturbing through the night. It's just a function of age. So in terms of how to try to get better sleep at night and to cope with the changes that come with age, it's very important to maintain a regular sleep schedule. So go to bed around the same time, wake up around the same time. Often when people ease off into retirement, they start having very variable sleep patterns. That's not good. Try to limit your daytime naps. Now, I would say once you're into your 80s, 90s, people have the urge to take a nap. They really need one. I'm all for that. Nap if you need to nap. But, if you're younger, sort of in your 50s, 60s, 70s, really try to limit your daytime naps because that helps consolidate sleep at night. And you also want to optimize your sleep environment. So turn off your devices like iPads and iPhones an hour before you get into bed. And just like this picture shows, you want to have a darkened room with blackout blinds and curtains. You want to minimize the noise around you and have a cooler temperature. You sleep better with cooler temperature. So here they have a fan. Only if absolutely necessary should you consider medication. And now some people have very disruptive, severe chronic insomnia. And so getting some sleep is important. So in those instances, yes, it is okay to consider medication. There are some supplements that can help with sleep, like melatonin or magnesium, and you should avoid benzodiazepines as much as possible. This is your sort of lorazepam category of medications. They can actually cause sleep breakdown over time. The next thing I want to touch upon is stress reduction. As we get older, there are a number of stressors. Many people get more health issues, either themselves, their partner, family members can get more health issues as people get older. There's also a lot of changes within the family, the social circle dynamics, just as you add in-laws and you add extended family and grandchildren, etc., it can change the family dynamics and can add more stress. There's also a lot of financial issues that come up as people get older. coping with changes such as downsizing, buying and selling property, moving your assets, losing the ability to drive, and even social isolation. Often friends pass on or move away or change neighborhoods. And so you can get increased social isolation as you get older. And this can cause a lot of stress, which can put it can have a very negative impact on the cardiovascular system. So it can be very challenging as you get older to address these, particularly if you have a limited family and friends or other social supports. So the important thing as you get older in terms of maintaining your cardiovascular health and reducing stress is to try and build social connections. Reach out to family and friends, get engaged in community activities, and join classes. There are many free classes available. Areas of ongoing research. So hormone replacement therapy, I guess asked about this a lot as women get older. There's a very complex relationship between hormone replacement and cardiovascular health. So whether you start HRT really depends on the timing of initiation. The impact on the cardiovascular system is associated with the timing. So if you start HRT before age 60 or within 10 years of menopause, it may reduce your cardiovascular risk without increasing the risk of things like cancer, blood clots, or stroke. But if you start HRT after the age of 60 or more than 10 years from the age of menopause, for example, if you started menopause at, 55 say 45 and you start medication at say, 58, more than 10 years from menopause, then you could increase your risk of side effects. And also we try to avoid using it in people who have established atherosclerosis or established blockages. HRT is not recommended for cardiovascular disease prevention. So even though if you started younger, within 10 years of menopause, it may reduce cardiovascular disease. We don't recommend it for preventing cardiovascular disease. If it is initiated for any other reason like hot flashes, brain fog, aches and pains, etc., and if it started early, it does not appear to increase and may decrease cardiovascular risk. Testosterone is another question I get asked about a lot. And there's no data that there's any cardiovascular benefit from using testosterone in men who are aging. If you do need it for low levels of testosterone, it does not increase the risk of a heart attack, stroke, or cardiovascular death. It could increase certain arrhythmias such as atrial fibrillation, potentially increase pulmonary embolisms, which are blood clots. So really you need to look at the risk and benefit in a very individualized way to decide if testosterone benefit outweighs the risk. Again, like HRT, testosterone is not recommended for cardiovascular disease prevention. And if it's initiated for another reason, like low testosterone symptoms, it does not increase the risk of some cardiovascular diseases, but may increase the risk of others. So again, very individualized approach to this. Other supplements, so there's no vitamin or mineral supplement that is broadly recommended for cardiovascular health. So if you go out there to the health food store, the drugstore, and it says, the whole wall of supplements to help you with your cardiovascular health, there's no good data to support this at all. You should use supplements only if you have a specific deficiency, like low iron, low B12, then you use it. Or use vitamin D, because in Canada, we don't get enough sunlight exposure, especially we're covered in winter, or for big parts of the year, we wear a lot of sunscreen, so we need vitamin D. The American College of Cardiology and the American Heart Association are clear in saying that the emphasis should be on a diet that's rich in vegetables, fruits, whole grains, legumes, nuts, etc., for getting your supplement, your nutrients. There's no recommended anti-aging supplements that actually help. And the downside is that you can have negative reactions with medications, side effects. Some can be very serious, and these can cost a lot of money with really no real cardiovascular benefit. So again, this is just depicting that you cannot get here your fruits, vegetables, fish, etc. You cannot get the nutrients from these in a pill. There is no such thing that exists. So don't waste your money. The other thing I would say is to ensure that you get regular health checkups as you are getting older. You need to see your family doctor regularly, at least once a year, maybe shorter intervals as you get older. You need to have your blood pressure, cholesterol, sugars checked, and other health screening for cancer, etc. If you don't have a family doctor, you need to find one. You can do Google searches for places in your area that are accepting patients. You can also go to the College of Physician and Surgeon website and under resources for finding a new doctor, there's some information there. It's not great. It's a lot of legwork you have to do on your own, but it is very important to try and find a family doctor. The other thing I would say is don't ignore symptoms. If you're having chest pressure, shortness of breath, fatigue, don't ignore this. Speak with your family doctor. If you have, it's important as you get older to have a brief list of your medical conditions, medications, and allergies in your wallet. We do see that when people, as they get older, if you do end up having a cardiac event like a stroke, if you have a heart attack, anything like that, if you have this information on you, you do have a better cardiovascular outcome. You do better than if you don't have that information with you. And another thing, very important, is to get vaccinated as you get older. You know, there's so much anti-vax information out there. People are sick and tired of getting their COVID shots, but these are important. From a cardiovascular standpoint, you do better with respect to cardiovascular health if you are immunized against flu, pneumonia, RSV, COVID, and shingles. There's actual data showing this. The other thing I want to speak briefly about is optimism. This is actually very important. The brain and the heart are connected by multiple connections, neural connections, and having a positive outlook, having an optimistic, hopeful outlook does impact the health of your heart. It does reduce cardiovascular disease. So as I mentioned, there's a lot of changes that come with age, and approaching these with a positive outlook is really important. It's important to acknowledge these and then try to find the change that you can make positively. So social networks and supports, as I mentioned, bolstering relationships with family and friends, and sometimes even seeking counseling or therapy. You know, if there's something that's been simmering for decades, you can address it in your 70s and 80s. It is never too late to address these because this can have a positive impact on your cardiovascular health. And then looking towards the future, there are emerging approaches that look at specific molecules as we age. There are new gene-based tests and therapies that are being tested, you know, specifically looking at your genetic predisposition for cardiovascular disease and then how to individually address those. It's not on the market yet, but it's all being investigated. And then AI medicine is another area that's very active in terms of research. AI algorithms that, for example, would look at your entire medical chart for like the last 60 years and say, what is your chance of having a heart attack in the next 5 years? Or what is your chance of having an arrhythmia in the next 5 years? So lots of information in terms of AI algorithms. And then eventually people will look at, you know, data is available, entire families, and what is the family's risk of having some sort of a cardiac event. Most importantly, I would say to conclude, optimizing cardiovascular health is a lifetime pursuit. It really starts from the time you're an embryo all the way on. So it is something that you do throughout your life. It's important at all stages of your life. The advice that I gave today applies, you know, to my children. Eat well, exercise regularly, don't stay on your devices, engage socially with your friends and your family. My husband and I in our 50s need to take that advice, and the aging grandparents. It's the same advice to everyone. It's the same tools, just used in different ways as we get older. Questions?
Wonderful. Wow. Well, first of all, thank you so much, Dr. Anselm. That was an amazing presentation. And I know I personally have learned a lot and a lot to sort of digest and take away. We've got lots of questions that have come in. A couple were around sort of supplements and dietary. So maybe I'll just try and group some things together because I know you addressed that in your slide about supplements. But one someone asked was about omega-3 and cod liver oil. So obviously, I think there's studied around omega-3 and stuff being good from salmon. Are pill forms of that or supplements of that like considered good, or is it just from food?
No, food would be the best source to get your omega-3s from. In fact, not too long ago, a study came out saying that supplements, omega-3 supplements, may in fact increase your risk of stroke. I don't know how good that data is, but all of it to say that there is no conclusive data that there's any cardiovascular benefit from using any supplements at all. The best sources for this is food, healthy food.
Okay, thank you. We have a question from Jacqueline asking if excess calcium is problematic for arteries.
So too much of anything can be bad. So yes, you should not be having too much. Again, these are the supplements, calcium supplements. So calcium from dairy is not going to, overwhelm your system. So healthy dairy, healthy sources of dietary calcium are good for you. But again, I would avoid calcium supplements unless you specifically need to take it. If a physician has advised you specifically to take a calcium supplement, then you should. But if you have not been advised to do that, then you don't need to.
Thank you. We also have a question from an anonymous participant, and I'll just read out. So they're wondering about the average age is to begin experiencing atherosclerotic calcification, and follow up to that, what tests should anyone with a family history of heart issues be requesting in an effort to practice preventative care?
So we do know that atherosclerosis often can start in your late teens and early 20s. So this is the process. And remember, I showed you that picture of the artery with the endothelial lining, so that we can start to see atherosclerotic type changes within those arteries, late teens, early 20s. It doesn't necessarily progress in everyone. We do know that with family history, smoking, diabetes, high blood pressure, the progression in that is more aggressive. So if you do have a significant family history, so we're talking about not your great-grandmother, but sort of your parents or your siblings having, the males having heart disease or stroke in their below age 55, or women in the family below age 65, those people should probably have some sort of screening in their, starting in their 40s and early 50s. So the most important part of the screening really is to check them for high blood pressure, high cholesterol, diabetes, all of the other risk factors, and then specifically looking at the coronaries, meaning the arteries. Again, it depends on the total risk. We may do stress testing. We may do a coronary CT or a calcium scoring. CTs and calcium scoring involve radiation, so we're careful in doing that because we don't want to give too much radiation over lifetime. But really, a doctor looks at all of your total risk factors starting in your 40s and 50s and decides what's the best way to screen you.
Great. We do have someone asking about sort of heart monitoring if they don't have a GP, and maybe what are the best ways to sort of be monitoring for that.
It's very hard if you don't have a GP, because really to get any sort of blood work, any kind of testing, any referral to a cardiologist, you need to have a GP. Sometimes you can go to a walk-in clinic and then they will can arrange for a referral. They can arrange some basic testing. But as I mentioned, it's very important for cardiovascular health to actually put the effort into finding a GP. And I fully understand how challenging it is out there. So I'm not saying all the effort needs to be on you. We have a broken system in that respect. And it's horrible out there. But if you do online searching, there are clinics that you can find that are accepting new patients. So find a family doctor.
Thank you. We have another question: if there's a way to determine how much visceral fat a person has.
And often that's very challenging to find out. It takes things like CT imaging, and again, that involves radiation. And so, we don't want you to have undue radiation exposure, because the fact is that there's nothing you can actually do about, just the visceral fat. It all comes back to healthy diet, exercise, and all of the things that I talked about. So that is the way of reducing your visceral fat. So if you're following all of that, you're going to be reducing your visceral fat. There's no point in doing imaging because there's nothing else we can do, on top of diet and exercise, which are very, very, very important. So whether you have visceral fat or not, you should be doing the diet and exercise thing. And your visceral fat is your visceral fat, and that's what you're genetically predisposed to. Of
course. I have another question about tests. Is there a test to determine the condition of your arteries?
Yes, there are. So as I said, stress testing, coronary calcium, coronary CT. A lot of this, as I said, involves, and then an angiogram. So a lot of this does involve radiation. So again, we don't just do it for everyone. Some of these are invasive procedures. So we look at your total risk. So that's where your family doctor starts by screening you, looking at your risk factors, and then deciding if you need to go to the next level for actually testing the arteries.
And is there a way to slowly remove plaque from arteries?
The best way is diet, exercise, and a statin. So it doesn't actually, it's very hard to get plaque regression. So if you have a blockage, it's very hard for it to all be gone, but you can certainly reduce it to some extent. More importantly, you prevent progression of what you have, number one. And number two, you prevent events. You prevent a stroke or a heart attack occurring from the blockage. So diet, exercise, and statin reduce the chance of having a problem once you have blockages.
And maybe just follow one last question, following up on you just mentioned statin. Someone's asking what options they might have if they can't tolerate statins.
So the first thing with the statin is, why aren't you tolerating it? Was it what kind of statin were you on? What was the dose? Most people tolerate statins at low doses and get significant benefit even at low doses. There's also gentler statins, like one called pravastatin, that by and large most people can tolerate at a low dose. Now, if you absolutely cannot tolerate any statin, even a gentle one at a low dose, there are other things like ezetimibe. There are some dietary fibers that can help with the cholesterol. There are injectable drugs. They're called PCSK9 inhibitors. So there are options aside from a statin, but the best data is for a statin, and I would suggest giving it a really good try, the reduced dose and gentler statin.
Right. Thank you very much. There's obviously, lots of questions around this topic and lots more in the chat saying what an amazing presentation. People are asking if we'll be sharing this, and we will share this on our website and send an email around after with Dr. Anselm's presentation. So I just want to say thank you. We do have to wrap up the questions for now, and I will pass it back to Julie just to wrap things up for us. So thank you, Dr. Anselm. Julie, you're muted.
I think I would have learned that by now. Thank you so much, Dr. Anselm, for such an amazing presentation. I know we're all going to be looking forward to receiving the slides and the recording from the event and using this as a very helpful resource as we look to continue to age well and share this with our friends and family. So thank you so much for an engaging presentation. And thanks to everyone for joining us today to take the time to learn more about such an important health area. This month, St. Joe's Foundation will be at local community festivals, like the Taste of the Kingsway this weekend. Come by and say hello, invite a conversation, would love to connect. We hope you'll also join us in November for our next Aging with Insight session, which will feature a practical conversation on wills and estate planning. November is Make a Will Month, so it's a timely conversation. And meantime, visit supportstjoes.ca, Aging with Insight, for more details. Thank you again, each and every one of you, for being here today, and enjoy the rest of your day and hope to see you next time.
Thank you so much, Julie. We will leave the Zoom room open for a few minutes at the end of the presentation. If anyone has any questions or would like to get in touch, I'll leave Julie's information up on the screen here, and we'll close the Zoom in a couple of minutes. Thank you again, Dr. Anselm, and thank you for everyone for joining us.